This program is brought to you by Emory University.
Good morning, everyone. Thank you for joining us for Fellows Conference this morning. We have two of our graduating fellows presenting some pretty interesting recent publications from the New England Journal. First, we're going to start with Dr. James Wodicka, who is a graduating fellow this year. He came to us through the ABIM track. And we'll be talking about antiplatelet agents in patients who are otherwise on oral anticoagulation in the setting of chronic coronary disease. And then Dr. Hassan Chami will be coming on after him to talk about the Digitoxin heart failure trial. And again, Hassan is a graduating fellow who came to us from Emory residency and is going to be doing a heart failure fellowship next year. The way we'll do this today, because both articles are really interesting and important, is we'll have James present his first, then we'll have some time for discussion, and then we'll do Hassan's and then some discussion on that trial afterwards. So James, take it away.
Alrighty. Thank you, Dr. Coley, for that intro. All right. Let's get started. The title of the article that I'll be talking about today is Aspirin in Patients with Chronic Coronary Syndrome Receiving Oral Anticoagulation. And this was named the AQUATIC trial. Now, if you were like me, one of the first questions I had was, how did they get the acronym AQUATIC out of that? And here you go. So it was the assessment of quitting versus using aspirin therapy in patients treated with oral anticoagulation for atrial fibrillation with stabilized coronary artery disease. So I thought that was interesting. I always think it's interesting, the acronyms that they come up with for these. So the AQUATIC trial. What were we looking at here? So they took patients with chronic coronary syndrome that were on oral anticoagulation, and this is plus or minus if these patients were already on a single antiplatelet therapy agent or not. All of these folks had a history of a PCI that was greater than 6 months prior to the randomization, and they were deemed to be at a high atherothrombotic risk, which we'll talk about in a second in terms of how they determine that. So as you can see here, you have folks that are on, the way it's divided up, folks that are on oral anticoagulation alone, or oral anticoagulation with a single antiplatelet agent. And they took each of those groups, they randomized them to aspirin 100 milligrams. This trial was done in France, and so their dosing is a little bit different than ours here, but aspirin 100 milligrams or placebo in both of these groups. If the folks were on a single antiplatelet agent that was not aspirin, that was either discontinued if they were put in the placebo group, or they were switched over to aspirin for the treatment group. The primary endpoint that they were looking at was cardiovascular death, MI, stroke, systemic embolism, any coronary revascularization, or acute limb ischemia, and their safety endpoint was major bleeding events. All right. So the inclusion criteria here, patients had to be greater than 18 years old, and as we said, all patients had some indication for long-term anticoagulation. We'll look at the data. Most of these folks were for atrial fibrillation, but there were some other indications as well. They were determined to have stabilized chronic coronary syndrome that had not had a PCI or an MI in the last 6 months. But they were the key for this trial was that they were specifically targeting a high risk group, a group that was high risk for atherothrombotic events. So to be included in the trial, you had to have a history of a PCI. It wasn't just some CAD that was picked up on imaging or stress test. Something had to have a history of having a stent put in, either for acute coronary syndrome, or if you had a stent put in that was outside the context of acute coronary syndrome, you had to have some sort of a high-risk feature. And the way that they define this were folks that had diabetes, folks that had diffuse multivessel disease, chronic kidney disease, you had a history of stent thrombosis, or a complex PCI, or peripheral artery disease. All of those were deemed to be high-risk features. So if you had PCI and one of those, even though it was outside of ACS, you could be included in this trial. Looking at so the key exclusion criteria. So as we mentioned, anything within 6 months, either PCI or MI, you were excluded. And they really tried to filter out folks that were at the high risk of bleeding. So if you had any recent bleeding event within 6 months of randomization, you were excluded. History of GI bleed or thrombocytopenia would get you excluded. History of gastroduodenal ulcers were all things that they were trying to kind of screen out folks that were kind of potentially at a higher risk of bleeding in this trial. You can see some of the other contraindications there. Some of the common things: severe renal or hepatic insufficiency, uncontrolled heart failure. One thing I found was interesting was lactose intolerance. That kind of caught my eye, but that had to do with how they formulated the medication. And so it actually had lactose within the medicine. And then, as typically seen, folks that were pregnant or breastfeeding were also excluded. All right, so this is a breakdown of the patients in the randomization. As you can see here, about 870 or so folks underwent randomization into the two different groups, aspirin versus placebo. Initially had some exclusions. Some people were excluded for major protocol deviation. And you got down to kind of in this range here, you're looking at about a little over 400 patients in each group that ended up being randomized in this study. You can see that in the aspirin group here, it says 101 did not follow up. Now, notably, 58 of those was because of death. About 35 withdrew from the trial during the period, but we're allowed to use the data that was already collected, and a few folks lost to follow-up. Similarly, on the placebo side, you actually had 37 deaths. 42 people withdrew, but could use the data up until that point, and a few folks lost to follow-up. So pretty similar on each side in terms of folks that were completely included from start to finish of the trial, a little over 300 in each group there. All right, so looking at some of the baseline characteristics, importantly, in these studies, to get a sense of exact population that we're studying, the average age for this study was about 72 years old, and it was 85% male. And then looking at some of the cardiovascular risk factors in these groups, the BMI was 28.5, but a third of these folks had diabetes. I kind of highlight that just because I think this is, in this specific population, this is lower than what we would see in the US in folks of chronic coronary disease. But notably, a lot of the same risk factors that we always think about in terms of hypertension, hyperlipidemia, some smokers, and notably, between the two groups, these risk factors seem to be pretty even. More looking at patient background, you're looking in this study, about 10% of the folks had a history of CABG. And most of the folks that had CABG, the median time since CABG was almost about 9 years. And as we said, notably for this trial, every single person enrolled in the study had a history of a PCI. None of them had just manically managed CAD. The median time since PCI was 3 years. About a quarter of these folks had their stent placed in the last 6 to 12 months prior to randomization. And then, as you can see, about 3/4 of folks had a history of an MI. And then as far as other characteristics of this population, you can see about a quarter of them had a history of heart failure. And as mentioned before, the indication for anticoagulation in this population was almost about 90% was for a history of AFib. And then baseline characteristics like hemoglobin and creatinine were all, as far as the averages, were all in the normal range there. All right, so let's get into the results here. So this is the primary endpoint that they were interested in looking at, and notably, this is a combination composite endpoint of cardiovascular death, MI, stroke, systemic embolism, coronary revascularization, or acute limb ischemia. So they combined all those things into their primary endpoint. And as you can see with the Kaplan-Meier curves here, you actually have an increase in this composite endpoint in the folks that got aspirin as compared to placebo with the underlying anticoagulation that they were on. And so anytime I see, or I think anyone sees this composite endpoint, we want to know what's actually really driving the difference here, like a lot of these studies. So kind of breaking this down a little bit further, it turns out that cardiovascular mortality is actually the biggest driver of this composite outcome. So again, looking at the curves here, in blue, you have the anticoagulation with aspirin, and in your red, you have the anticoagulation with placebo. And as you can see, over time, you actually have an increase in cardiovascular mortality with the addition of aspirin. Another kind of subplot here in terms of kind of taking some of that composite outcome and looking at specifics. So this is the rate of atherothrombotic events. Again, in blue, you have your DOAC with your aspirin, and red, you have your anticoagulation with your placebo. Pretty similar, these curves throughout. Just showing that even with the addition of aspirin, there wasn't any reduction in atherothrombotic events in this patient population. So another thing that they looked at was looking at death from any cause. And so in this plot is including cardiovascular death. But death from any cause, you can see here the anticoagulation with aspirin was greater than significantly greater than the anticoagulation with placebo. And we'll get to looking at this in a little bit in terms of trying to distinguish exactly why the death was higher in the aspirin group. And so these are just looking at the actual numbers here. I know folks like to look at things in different ways, but this is that primary outcome here highlighted in this red box. You had 73 folks that had met that primary outcome in the aspirin group, which is about 17% versus the 53 folks in the 12%, about 12% in the placebo group. And notably, this was the reason that the trial was actually terminated early. The original goal for them was to enroll, I think it was around 2,000 or so patients, ended up in about the 800 range, and an independent data reviewers that were looking at this, because of this increased cardiovascular death and death in the aspirin group, actually terminated this trial early. Again, looking here at the exact numbers for cardiovascular death, 33 in the aspirin group and 19 in the placebo group. And really just breaking down kind of along here, the different numbers, you can see that they measured net adverse clinical events in the aspirin group were higher compared to the placebo group. Again, we're highlighting here death with any cause was higher. And then the thing that we looked at the graph of earlier, but these atherothrombotic events were very similar between the two groups. Which was, of course, interesting to see, given that that was a thought that aspirin would potentially reduce some of those events. So similar numbers, relatively similar numbers across the board, with the exception of that increase in both cardiovascular and overall death in the aspirin group. And so certainly in these trials, another thing that we're very interested in is looking at major bleeding. And as you can see in the plot here, and folks that got aspirin in addition to their anticoagulation were at a significantly increased risk of having a major bleed. And this is not surprising for us. This is somewhat intuitive, but also has been shown in previous studies that the addition of aspirin or other single antiplatelet therapy to anticoagulation will increase your risk of having a major bleed compared to anticoagulation alone. And this is just looking at those exact numbers. So we can see here that in the aspirin group, we had sorry, meant to include the header on the top of this, but in the middle here we have the aspirin group had 44 events of a major bleed, about 10%, and then in the placebo group there was a 15 events for about a 3.5% rate. So almost a threefold increase in risk of having a major bleed when you included aspirin in these folks' therapies. They also looked at incidents of having any bleed, not just major bleeds, and then they went down and they looked at basically using a whole bunch of different criteria to try to classify the different type of bleeding and all that. Basically, suffice it to say, no matter how you sliced it, the folks that were having aspirin in their regimen were at a significantly increased risk of having a bleed. All right, so one of the things I was most interested in kind of hearing about this data was trying to figure out exactly why you were seeing this increase in death. And admittedly, we'll go through this table here, but there's not really a slam dunk answer, it appears. So when you're in our middle column here, we have your anticoagulation with aspirin, and we have your placebo in the right column. So these are initially they're looking at cardiovascular deaths. So you can see cardiovascular death is indeed higher in this aspirin group, as we discussed. But the exact reason why is not entirely clear. Heart failure deaths were pretty similar. Death from an MI, death from a stroke, sudden death, acute or mesenteric ischemia, all those are really similar. And then, of course, you get left with this rather unsatisfying unknown cause, which was actually a fairly big difference in those two groups. So not entirely clear what was causing the increased cardiovascular death. And then they also broke it down looking at non-cardiovascular causes of death. You can see in the aspirin group, you had 25 of those and 18 in the placebo group. Again, you see pretty similar numbers. Actually, ironically enough, the only two folks that died of a major bleed were in the placebo group. Cancer rates were pretty similar, infection and sepsis, slightly higher in the aspirin group, but again, you're left with this kind of other one that showed kind of most of the difference there. So not entirely clear, despite the fact that the folks that got aspirin had a higher incidence of cardiovascular death, overall death, and some non-cardiovascular causes. The exact reasoning there is not clear. All right, so looking over the specific study, so some of the positives, and of course it's a multi-center, double-blind, randomized, placebo-controlled trial, and specifically they were targeting patients with a high atherothrombotic risk, and I think this is important, and we'll look at briefly some other past studies on this topic that tended to have a pretty low incidence of atherothrombotic events. And so they were specifically trying to target this higher risk folks that have had PCI, that had these high risk features. And I think it's a little bit of a double-edged sword, but the one positive is they specifically focused on aspirin. So for their single antiplatelet therapy, they were really only focused on that one. There weren't any P2Y12 inhibitors included. So they wanted to see specifically, does aspirin make an impact there? And notably, the Bayer Healthcare, so Bayer Aspirin, was actually a funder of the study. So honestly, it makes me believe the results a little bit more, given that it was kind of so one-sided, the opposite direction as probably they had hoped. Some of the limitations of this study, of course, the early termination always makes you wonder if you had reached, higher numbers, what that would look like. But I think the trends from what the data that you have are pretty clear, and it makes sense why it was terminated early. They had a very slow enrollment. Notably, their enrollment started in May of 2020. So they believe that the COVID-19 pandemic contributed some of that slow enrollment. Notably, the authors specifically say in their study that they don't think beyond the slow enrollment that COVID-19 played any role in the outcomes, the data that we were seeing. One limitation is the study was completely conducted in France. So you have to potentially extrapolate that to other populations. And then, as I mentioned in the positives that they focused on aspirin, one of the limitations I see is that most of the time now in these folks, and we'll look at the guidelines here in a second. But a lot of these folks are no longer on aspirin, and folks that have had a PCI were typically using other single antiplatelet agents as opposed to aspirin in this population at this point. All right, and so just kind of providing a little bit of context to the study that we just went over. So this was the AFIRE trial, which was published in 2019. Another multi-center, double-blind, randomized placebo-controlled trial that looked specifically at patients with AFib that had a PCI or CABG greater than 1 year prior to the enrollment in this study. So this study was specifically it looked at almost 2,500 patients, and they gave them everyone was at a baseline of Xarelto for their anticoagulation, and then they either had a single antiplatelet agent or a placebo in this trial. And this trial, similar to the one that we just looked at, the AQUATIC trial, actually was also stopped early due to an increase in major bleeding and mortality in the folks that were receiving the antiplatelet agent. So some similarities there from the trial that we just looked at. And then another study, this is the EPIC CAD trial. This came out just in 2024, relatively recent here. In this trial, so this was an open label trial, but similar randomized trial that looked at folks that had AFib and stable coronary disease. And all these folks were put on edoxaban and plus or minus a single antiplatelet agent as well. And here, the population wasn't as high of a risk as the population in the AQUATIC trial. And the event rates, as far as like ischemic event rates, were pretty similar between the groups in this trial. However, they did show that the folks that had the single antiplatelet therapy, in addition to their DOAC, were at a significantly higher risk of bleeding. So I think some of these results were kind of some of the foundation of why they were trying to do aspirin in these higher risk patients. All right, so that leads us to kind of looking at like what are our current guidelines on these, and how might this trial contribute to that. So these are the 2023 AHA ACC guidelines on chronic coronary disease. And so we'll kind of just go through this. It is currently, and this gets into some of the more acute phase here, but it's kind of going through this. In patients, it's a level 1 recommendation in patients who have chronic coronary disease who have undergone elective PCI to be on DAPT for 1 to 4 weeks, and then followed by clopidogrel for 6 months in the setting of having an underlying DOAC on board. It's a 2A recommendation, and these folks who have undergone PCI who have to be on anticoagulation for continuing aspirin up to a month, if it can be reasonable in these folks that are a high thrombotic risk. And then you see it's a 2B recommendation in patients who have chronic coronary disease with anticoagulation to discontinue aspirin therapy with DOAC alone a year or so after PCI. And then it says in patients with chronic coronary disease who require anticoagulation, DOAC monotherapy may be considered if there is no acute indication for concomitant antiplatelet therapy. So that's a 2B recommendation as well. So these were from guidelines from just a couple years ago. And you can see it's kind of mapped out here, what I just went through in this graph on the right, that in most cases, folks that either did not have a recent PCI or never had a PCI are on DOACs alone. The recent PCI being about 6 months or so is the kind of the standard cutoff at this point. A lot of this it stems from some limited studies that we had gone through there in terms of like the AFIRE trial, but also kind of consensus opinion. So I think the current study, the AQUATIC trial, will kind of add to this and kind of further, hopefully, kind of like further solidify some of those recommendations as far as dropping antiplatelet therapy. And this similarly, but this is just also looking specifically at the AFib guidelines, which came out in 2023 as well. And there, this is the only point where they had addressed this degree. So it says patients in atrial fibrillation with chronic coronary disease beyond 1 year after revascularization, or in CAD that hasn't required revascularization without history of stent thrombosis. Oral anticoagulation monotherapy is recommended over the combination of oral anticoagulation and single antiplatelet therapy to decrease the risk of major bleeding. So that's pretty consistent with what we had seen, only except they're looking, they only mentioned the major bleeding, and the study, as we said, actually looked at saw a difference in mortality as well. So the data that we have from the AQUATIC trial will probably only further emphasize this recommendation here. So main conclusion that we can take away from this study is that in patients with stable chronic coronary disease, defined as greater than 6 months post-PCI, that have an indication for anticoagulation, aspirin should not be utilized to prevent any thromboembolic events, even in patients that are deemed a high risk of atherothrombotic risk. And that is all I have for now. Thank you very much for listening, and happy to take any questions and comments on this study.
Thanks, James. That was a really nice summary of some of the data on this topic. I think when I looked at this study last night, the thing that bothered me the most were those sort of unknown deaths or, causes of death in the cardiovascular people who were deemed to have a cardiovascular cause of death. And I wondered if when you were reading this, because I didn't have enough time to look through all the supplement stuff, they must have had some criteria to diagnose cardiovascular death. So what criteria put them in that unknown category? I wonder if you sort of ran across, like, was it elevated troponin, or like, how did they figure out that it was a cardiovascular death if they weren't chalking it up to like MI or something else?
Yeah, admittedly, they didn't really go into that. I was looking for that more as well, and then maybe I need to do a little bit more digging through their protocol or anything like that. But I didn't, when I was looking at it, I didn't see their exact reasoning in terms of how they determined that it was a cardiovascular death, but of an undetermined cause. So admittedly, I'm not sure. And I agree that that is a bit frustrating, because that was the whole reason that the study got stopped early, was because of cardiovascular death, and that subgroup of unknown cause seems to be what was actually driving it. So not entirely sure.
Okay. We'll take some more questions. We'll probably do questions for another 5 or 6 minutes and then let Hassan come on. So welcome some comments.
Stan Sherman, can you hear me?
Yes.
Yeah, I was just wondering, in France they like to smoke. Was there any subsets that they looked at for smokers versus non-smokers? And the other thing was, and I'm sorry if I missed this, was there one DOAC over the other that they tended to use in this study?
Gotcha. Yeah. So the of this population, about 10% of them were smokers. They did do some subgroup analysis to break down for a lot of various factors. I don't remember specifically if smoking was one of them, but when they did do those subgroup analysis, almost all of them favored the placebo over aspirin. I think the only one that was even kind of like close to being in the middle was actually a subgroup of women. But as I said, they made actually a very small group, only about 15% of the population in the study. So it wasn't statistically significant or anything, but all the subgroup analysis they did was more favoring towards placebo. And then the other thing, so as far as the anticoagulation, so they left folks on whatever anticoagulation they were on. About 90% of that was DOACs. So I believe it broke down to about 2/3 of people were on Eliquis, about 25% were on Xarelto, and then the folks who were not on a DOAC were on warfarin. So about 10% of the people were on warfarin.
Thank you. Good talk.
Thank.
Hey, it's Peter Blanc. Can I ask a quick question or make a comment?
Of course.
This is sort of weird, isn't it? And yet, I sat on the DSMB for the same kind of trial that was done in the structural world when people were trying to figure out whether or not aspirin was good for you if you had a aortic valve. And the short version was that study also was, we stopped it early because of unknown deaths. And we finally figured out that it must have been aspirin that caused cancer, which is obviously not the case. But it was very strange that this seems to be a repetitive finding in a lot of these trials. And it's counterintuitive because we've always thought that aspirin is good for people that have coronary disease. And why are these people dying of some kind of cardiac problem? They're not bleeding particularly more, though they do bleed more. And it isn't the bleeding that causes their deaths. So one of the things that troubles me about a lot of European trials is that the Europeans are very careful about stopping trials early because they are worried that people will come back and say they should have stopped the trial early when they do not, even though the numbers here are relatively small. And I just wonder if this is a small numbers issue that brought these outcomes to sort of a curious conclusion. What do you think about that?
Yeah, I mean, I think that's certainly possible. It's something that they mentioned in their article as well. Is that you know, as I said, they were trying to enroll 2,000 patients and ended up at about 800. And as you mentioned, you saw the numbers there in terms of, you know, the trend is what it is, but certainly, especially when the deaths are, you can't really find an exact cause for them. It's possible that it could, you know, it could be some degree of error there just because of the low numbers. I certainly, yeah, I agree with that. I don't know if anybody else had comments on that as well.
See, Dr. Dickert's got his hand raised.
Yeah, so I'm glad Peter raised those questions. You know, just as a bit of an aside, you know, Peter's experience on a DSMB in the prior study that he mentioned is important. I also am on a number of DSMBs, and it's an interesting and sometimes really tough decision to decide when to sort of stop trials and not. You know, in this case, I think one of the things that's important is I'm sure the DSMB was fully prepared to see this difference in bleeding, right? You know you're going to have some adverse effects in the aspirin group. I'm sure what sort of drove this was the fact that there was absolutely no signal of any offsetting benefits. And so I think it's at some point, you know, whether it was truly a safety assessment or clear sort of sense of futility in which it's going the wrong direction and you know you're never going to see a benefit, be interesting I haven't seen in detail the extent to which they justified it one based on the other, but you can stop trials based on overwhelming benefit. We know studies that tend to stop early for benefit tend to overestimate benefit, but futility and safety are sort of different kinds of assessments. But I agree, it's sort of difficult these are always difficult decisions to know when to stop trials. The other thing I was going to point out that I think was really nice about the design of the trial, you highlighted at the very beginning, but not as much in the end. I was looking back to see what the distribution were, but they did a kind of an interesting design where they stratified it based on whether you were or weren't on aspirin in the beginning. I thought that was a pretty creative attempt to make sure that they weren't getting people who were sort of selected out as being more or less reasonable to be on the therapy at baseline. I just think that's a nice design feature to make sure that they got as representative a population as they could.
Yeah, no, I certainly agree with that as well. And it was interesting to see that actually, I mean, there were more people that were on an antiplatelet agent prior to enrollment than were not. which, given the results of the trial, I think is certainly interesting.
So before we wrap up this presentation, and thank you again, James, I'll ask maybe Dr. Dickert and Dr. Block and Dr. Sherman. So are you would you stop aspirin in a patient like this, that in this population, high atherothrombotic risk?
I was going to ask, this is Peter again, I was going to ask the group about that. I mean, having looked at this trial, do you think that aspirin is bad for you if you have a coronary problem? And, you know, I just don't think that the data are strong enough to say, no, I would not do it. But, you know, we also know that aspirin is bad for old people now, right? And old people shouldn't have aspirin anymore, even though they have a coronary syndrome in the past. And that isn't because of the bleeding, although they all bleed. And I'll be really candid, I stopped aspirin. But I'm not sure I would always stop it in my patients. That's sort of a nasty way of putting it, but I think we just don't know.
Yeah.
I mean, I think on the background of oral anticoagulation, which I think that's the difference between this and a lot of the sort of prior trials. Obviously, there's some, you didn't mention this, James, but I think there's the sort of fascinating story of sort of low dose versus higher dose DOAC, which had these also really weird kind of paradoxical effect. But I think if you're on oral anticoagulation in this context, I think I'd feel pretty darn comfortable stopping aspirin without any. There's just no evidence of an offsetting benefit.
I just wonder if has anybody seen DOAC plus clopidogrel? You know, maybe it's a less toxic antiplatelet agent.
And that might be another future question. Dr. McDaniel says, I think there's no role for aspirin in 2025 outside of 3 months after PCI. And we're getting nods of agreement from Dr.
How about clopidogrel?
So at least some of the studies, some of the studies have included that, but at least to my knowledge, there wasn't one that specifically looked at like one P2Y12 inhibitor. So a lot of these studies that a couple of which I touched on just said, a single antiplatelet therapy. Clopidogrel was part of that. Aspirin was part of that. So at least from those studies, it wasn't specifically looking at clopidogrel.
I really wish we could continue the discussion, but I want Hassan to have time to discuss his studies. So I'll let him get set up now, and we will probably go a little past the 8:30 mark. So if you're able to stay, that would be great, and discuss Hassan's study as well.
Good morning, everyone. Thank you, James. Thank you. Happy Friday. Okay, so I'm going to be presenting a recently published trial, the Digitoxin in patients with heart failure and reduced ejection fraction, the DIGIT-HF trial. So a little bit background about cardiac glycosides in general. As we all know, they're derived from foxglove. They have been used in heart failure for more than 200 years. And the thought was like they inhibit sodium calcium ATPase pump, so they increase contractility, but they can also can modulate the neurohormonal abnormalities that we see in heart failure because they might affect the baroreceptor function. They can have they increase vagal tone and they can inhibit the sympathetic nervous system, and somehow they might have an antifibrotic effects that can modulate the impact of prolonged aldosterone exposure. So the main glycosides, the cardiac glycosides that are available are digoxin and digitoxin. Digoxin is available in the US, digitoxin is not, and it's available more in Europe and other countries. And they're both, they have this similar mechanism of action, obviously, but they have distinct pharmacokinetics properties, which for digitoxin, for example, they have more hepatic clearance, so we can use them with more comfortably in patients with renal disease. They have longer half-life, and they have more stable levels, so we worry less about like the toxicity and high serum levels. So in terms of what we have in the US, the FDA approved oral digoxin for the treatment of heart failure, despite being used for heart failure for many years. It's only approved in the 1990s, and it was approved not because of any mortality benefit, because we didn't have any study showing that. It was mostly because of the potential to reduce hospitalization due to worsening heart failure. And this is mostly from the DIG trial, which was published in the 1997, and related meta-analyses and post-hoc analyses following that trial. So to date, the use of cardiac glycosides in heart failure is basically just in addition to GDMT, and should be considered to decrease hospitalization with the level of evidence with the grade of 2B, because we lack the evidence on benefit. So that's why with the new modern treatments of heart failure that have been shown to have mortality benefits and improve hospitalization, they decided to kind of do a new study on top of GDMT. So the goal of the trial was to evaluate the efficacy and safety of digitoxin at low concentrations in HFrEF patients that are treated with current medical and cardiac device therapies. And the study was published last month on September 25 in the New England Journal of Medicine. So it's pretty recent, and it was presented in the ESC conference. So basically, the study design, it's a phase 4 multi-center double-blind placebo-controlled trial. It included 65 sites in Austria, Germany, and Serbia. And basically what they did, they did a one-to-one assignment of digitoxin versus placebo on top of GDMT at a low dose for the digitoxin. And the median follow-up was 36 months. The inclusion and exclusion criteria, basically, they picked kind of a little bit more sick patients with heart failure, and they're mostly symptomatic with EF less than 40, mostly NYHA 3 and 4. Some of the patients were also EF less than 30% and NYHA class 2. But the patients should be treated with evidence-based therapy for at least 6 months. The biggest exclusion criteria, the long list of inclusion and exclusion criteria, nothing really specific for the trial aside these. For the exclusion, anyone with recent MI or decompensated heart failure, obviously severe hepatic or renal disease, if they have significant arrhythmia, and especially if they don't have a device, because we know it's going to be, especially if they have like bradycardia, if they don't have a pacemaker, and so on. So these are the main features of the exclusion and the inclusion criteria. The main outcomes for the trials, the primary outcome, they decided to use composite of death from any cause or hospital admission for worsening heart failure, whichever occurred first. And they had multiple secondary outcomes. I summed them up into death from any cause and any hospitalization. So basically, it could be cardiac, non-cardiac, or hospitalization, whether it's heart failure related, cardiac, other than heart failure, or non-cardiac as well. Aside from the primary and secondary outcomes, they also had some safety outcomes, which are mostly serum digitoxin levels, and some adverse and serious adverse events, which could be also cardiac and other non-cardiac side effects. So the statistical analysis they used, they did a like for the primary outcome, it's time to event analysis, which was reported as hazard ratio, and they used the Cox proportional hazard model, so time to first event. And they did the efficacy analysis in a modified intention to treat population, because there's some kind of patients were left the intention to treat analysis, so they had to do a modified one. The main problem they had was the original design was based that they calculated like they need almost 2,200 patients and 734 events to provide a trial 80% power to show the superiority of the digitoxin over placebo, and that will provide a hazard ratio of 0.81. But the enrollment was slower, and they had to extend the duration of enrollment, and they eventually randomized almost 1,200 patients after extending the recruitment duration. So that's one of the problems they faced. They didn't really comment on why it happened. It's just like the events didn't happen. I'm not sure if COVID at that time was a problem as well, and they didn't comment on it specifically. So in terms of the patient flow chart, so they recruited patients from May 2015 to September 2023. They started with 1,250 patients almost, and eventually they underwent 1,240 underwent randomization. Some of these patients like didn't take the medicine, or they didn't like follow the protocol specifically, so they had to take them out. And then the final number of patients who were involved in the modified intention to treat analysis was 1212, where 613 patients were assigned to the digitoxin group, and almost 600 patients assigned to the placebo group. 17 patients and 8 patients were lost to follow-up after randomization, respectively, in each group. So going to the study results, so the baseline characteristics basically were well balanced between the trial groups, and they had almost a mean age of 66. It represents 80% of men. They had 20% women, and the majority, I didn't list all the baseline characteristics, but there's no differences in the other ones like BMI, kidney function, other comorbidities. But mostly the majority of the patients were, as I said, class 3 and 4 NYHA class, so a higher burden of symptoms. And the mean EF of the patients was around 29% in both groups, or like 29 versus 26, so not really significant difference. 27% of patients had AFib, which is is like known to be used, digoxin to be used in AFib as well. The most important baseline characteristic, I think, is the current therapy for heart failure, where they had almost more than 90% of the patients were on beta blockers. Around 40% of patients were on ACE, ARB, or ARNI. And for MRAs, it's around like 70 to 80%. The SGLT2 inhibitor use was a little bit less than that, because I think at that time it wasn't implemented that much. But it's around 20%, and it's similar in both groups. Also, the cause of the heart failure was also kind of well balanced between. So ischemic versus non-ischemic, it was around like 50% of each group. So going to the primary and secondary outcome results. So for the composite of death from any cause or first hospitalization of heart failure, they had 242 events in the digitoxin group versus 264 events in the placebo group, which is like 39% versus 44%, which was, I would say, statistically significant, with a hazard ratio of 0.82 and a confidence interval between 0.69 and 0.98. So it's just excluding one. And if they divide the component of the primary outcome, they like death from any cause by itself and first hospitalization, there was no statistical significance. So as you can see, they did a median follow-up of 36 months here, and the absolute event rate was more with the placebo group, 44% versus 39 again, and there was an absolute risk reduction of almost 4.6% over that median period of time. And based on these, the calculated number needed to treat was 22 patients to be treated over a 33-year period to prevent one composite event. In terms of the secondary outcomes, sorry, not the secondary outcome, showing each component of the composite outcome, as you can see, both curves were crossing, and there's no really statistical significance in that regard. After they did the primary and secondary outcomes, they did also some pre-specified subgroup analyses to see with each like with each component of the patient characteristics to see if it favors digitoxin. But it was like an underpowered analysis because of the number of patients. I'm just displaying it here. It's pretty it has a lot of pre-specified groups. Some of the pre-specified groups showed some benefit, like they favored digitoxin, including patients with low blood pressure or higher heart rate. But most of the other comorbidities in these pre-specified groups were kind of neutral and didn't show any like didn't favor digitoxin, so to speak. In terms of safety outcomes, which is also a main concern when we use digitoxin or digoxin because of the neurotherapeutic index. So what they did, they checked levels at 6 weeks, and based on that level, they decided to go up on the dose or go down. And usually target dose is 8 to 18 nanogram per milliliter for digitoxin, and toxic levels are achieved when you have more than 35 or higher than that. So at 6 weeks, the levels they had were like almost within the target range. And at 12 months, they did another check just for scientific purposes, and it was like around 13, around also the same target within 8 to 18 or something like that. In terms of serious adverse events, they happened in 4.7% of patients on the digitoxin group and 2.8 in the placebo group, and it was mostly cardiovascular. But it's about one case out of all the population. Other adverse events led to stop the drug or the placebo happened in 56 patients and 61 patients respectively in both groups. So there was no major safety concern, but there's a signaling toward like there could have more serious adverse events in the digitoxin group, but this wasn't specifically statistically significant. So the main strength of the trial is it's the design of the trial by itself. It's randomized, double-blind, placebo-controlled. It had a long medium follow-up period, and I think the main issue is main strength is that it asks a clinically meaningful composite endpoint and tries to answer a really good question: is whether any additional therapy to the current GDMT that is well studied, well implemented, does it have any benefit? Especially now with these days, with these advanced patients, if they are not candidates of any more advanced therapies. But I found that there's a lot of limitations of the study, mostly with their design and their enrollment. So I would say they were underpowered relative to the original plan, especially that the observed events, the observed events were not as much as they wanted, and this would affect the statistical power of the study, resulting in the results would be more fragile and statistically fragile. So we need to draw conclusions out of these results with caution. And also, even with the composite outcome, it was marginally statistically significant with the p-value of 0.03, and the hazard ratio confidence interval was just around 1, with the upper level was 0.98. Also, another key feature was that the composite endpoint, it's a composite endpoint driven result. So when they did the point estimate at the median follow-up of 36 months and showing the benefit of digitoxin, when they did the separate one, neither component of the composite outcome showed any nominal statistical significance by itself. So it has to be also interpreted with caution. Also, among the pre-specified subgroups, as I said earlier, they lack statistical power, so we cannot really use them to draw any conclusions specifically, but they might be like for later on in the future to kind of draw more, to do more studies about. A main limitation for us here in the US is that the study is about a digitoxin, which we don't basically have. So we cannot generalize to all the patients due to availability at least. But digoxin, there's the ongoing digoxin trial is the decision trial, and we're going to have to wait for these results. So, and in terms of what they concluded after all this, despite the limitations and the strength of the study, was in patients with heart failure with reduced EF who are on GDMT, treatment with digitoxin led to a lower combined risk of death from any cause or hospital admission for worsening heart failure than placebo. I'm not sure if I can really, I mean, based on the study itself, yes, we can probably make that conclusion, but I'm not sure how, if this will impact the guidelines or change any of the level of recommendation. I doubt that, and I think we will need more studies, more well-powered studies to include cardiac glycosides on top of GDMT for that purpose. I know I've seen it multiple times when we are on heart failure service that we use sometimes digoxin in patients on GDMT, but we know it's mostly to prevent hospitalization and based on the previous trials that we had, mainly the DIG trial. And that's it.
Great. Thanks, Hassan. I see some of our heart failure specialists on the Zoom today, so I'll sort of cede the floor to them for comments and certainly questions as well to the rest of the group.
Oh, I lose my screen.
Hi, Hassan. This is Mahmoud. Good presentation and a good choice of a trial that is certainly interesting, and I'm really eager to see what Neil thinks about the design and the enrollment. I found a lot of interesting things about this trial and its design, and the difficulties that they faced in enrollment and slowness and all that. But mostly, you know, the main limitation, in my opinion, in addition to what you mentioned in it, is that we know that digoxin reduces hospitalizations, at least by the sub-hoc analysis from the DIG trial. But also there's been contemporary data that suggests that it really reduces symptom burden. And it's interesting that this trial, despite them having the time to analyze, a lot of time to analyze the data, they have not commented on the symptom effect or changes in symptoms, especially in New York Heart Class or any other patient-derived results like quality of care and all that, quality of life metrics, so on and so forth. So that was a main limitation and kind of a disappointment in the publishing of this article. Just for the group, digoxin has been stirring a lot of discussions lately, and as you can see, there's coming up too. This one came up just a few months ago. There's another U.S. trial, the decision trial. I think in the contemporary era of newer GDMT, we will see what the effect of digoxin is. I do think it has a role in certain patient population and certain patient characteristics. At least this is my personal bias towards it. However, we will see what the randomized clinical control trials will show us. So I do think this trial definitely, though it is not a very slam dunk positive trial, however, it does show us that there may be a possibility of a role of cardiac glycosides in the toolbox of medicines that we have for these patients.
Hey, Hassan, this is Kunal.
Hey.
Great talk. I am one of the proponents of digoxin on the heart failure service. And so I think I was eagerly awaiting your presentation. I think from my standpoint, the time when we reach for DIG on the heart failure service is when the patient has sort of reached whatever limit of GDMT we can provide and still has a high burden of symptoms. And at that point, we know that the only oral form of an inotrope that we have available is digoxin. And whether the inotropy is marginal or not, there is some inotropy that digoxin provides, and it's the only oral inotrope we can prescribe. And it has all of its limitations, but in our patients, we never prescribe more than 125 micrograms, and we keep it at that dose. I was curious in this study what their GFR cutoff was. I know you said renal dysfunction was a contraindication, but what was their GFR cutoff? Was it 60 or was it below that?
It was 60.
60, yeah. So, I mean, I think for us, this is something we can learn from, that there is at least a role. I don't think this is a groundbreaking trial by any means. Has a lot of limitations, but I still love my smidge of DIG, and I'm going to continue doing that for the patients who are marginal and have no other options.
Kunal, I'm glad that you brought this up, and I am, as you, a proponent of digoxin as well, and in certain patients, and I like it, and I do not stop it. And the smidge of DIG, I think, is a good way to put it. However, the advantage of digitoxin, though, that is predominantly enterohepatic cleared, that the renal effect or the renal dysfunction was not an issue, at least in this trial. So that's one positive advantage of digitoxin that we don't have here available in the United States. But I agree with you.
May I make a quick comment? It's Peter again. I had the opportunity of living through the time when we only had digoxin and some mercurochromate for patients. And digoxin and digitoxin, we used to call it digitoxic, by the way, because it tends to be a little bit more side effect prone than digoxin if given carefully. But I'm a proponent as well. But I always wondered why it was that the addition of DIG made a little bit of difference, and in the trials has shown a decrease in hospitalization, and wonder whether it isn't that if patients who have heart failure have intermittent atrial fibrillation and they have some cardiac glycoside on board, that they don't feel as badly and don't go to the hospital as quickly with a rapid heartbeat. And in fact, in this trial, it shows that the heartbeats or the heart rates were a little bit lower in the DIG-treated patients. And I've always wondered whether that isn't really the thing that makes patients feel better should they go into a brief period of PAF and then decide they don't have to go to hospital or don't have to feel quite so badly because it improves them a little bit faster than if they're on nothing at all. Sort of an interesting way of thinking about it. I have no proof of that one way or another, but I just wonder if that isn't the culprit.
Yeah, I mean, hypothetically, that's what they suggest. Like, the addition of digoxin will increase vagal tone, lower heart rate, especially in patients who did not tolerate other GDMT, and that could be driving some of the improvement or to prevent hospitalization, as you said.
Yep.
Dr. Block, thank you for your comment, and it's an interesting idea. But what's powerful about this trial is that they started the digoxin in this particular era on top of really good medical therapy that is guideline driven. If you see the number of patients on heart failure beta blockers in this trial, it was almost more than 90%, and more than 70% were on an ACE-ARNI or ARB, on top of almost correct me if I'm wrong, Hassan, but it's 70% MRA, which is unheard of in clinical trials. And the authors did a good job contrasting the patient characteristics of this trial to other powerful trials like the DAPA-HF and EMPEROR-Reduced. So I just wonder that if, the background medical therapy that we know works and the long period of follow-up had anything to do or any impact to do on the composite result endpoint. So.
It's definitely possible that the GDMT is driving the the results of the study instead of Digitoxin, because we know they work. I'm not really sure if even like when we use SGLT2 more, let's say if they had 60% of patients on SGLT2, would we see some benefit on the composite outcome, or it would be just masked by the benefits of the GDMT? That would be a question for later on, maybe in the future when we are implementing SGLT2 more. But yeah, I can't really tell if it's just purely due to Digitoxin versus the GDMT, and just the follow-up, as you said, is driving that.
Any more questions or comments?
One thing, and this is Dr. Clements.
Yeah.
This is reminding me, and Peter, you'll remember this, making rounds every day with patients with heart failure. We all used to have to check for digoxin or digitoxin toxicity. You know, they get nauseated. Especially the elderly people, they get nauseated. Their saliva tastes bad. I remember walking into a room one day and finding almost a box of Kleenex on the floor because they had to get rid of their saliva. And Dr. Logue was a great proponent of looking for digoxin toxicity, about made a living off that. So that's not so much nowadays, but we still watch for that. It used to be a big deal. Thanks.
I'd agree with that, Steve. I think that's one of the things that we worried about, hence the digitoxic business. But my grandmother took digoxin and had eye problems as well. They get little flashes of light in the corners of their vision as well. There's a whole constellation of side effects that you have to worry about if you're going to give it. But a smidge of dig is probably still not a bad idea if you're strapped and can't make the patients better with your standard therapy.
All right. Well, great. Thanks, everyone. I will definitely be thinking about that smidge of dig in my heart failure patients. Thanks, everyone, for staying late. I know we went long, but they were two really great trials to discuss. Have a great weekend, and we will see you next Friday.
The preceding program is copyrighted by Emory University.